Let us now talk about other pathologies that can cause cirrhosis. So we just talked about viral hepatitis. We're going to talk about this later. So now we're going to talk about alcoholic liver disease. So this is damage to the liver resulting from chronic alcohol use. So acetaldehyde, that's a metabolite of alcohol, it's going to lead to the liver damage. Now there are 3 different stages of alcoholic liver disease, and they usually progress in the order that I'm going to tell you, but they don't necessarily have to. So the first one is called alcoholic fatty liver, aka hepatic steatosis. Steatosis just basically means fatty change. So that liver is it's gonna turn fatty. Okay, it really does. If you look at it in gross, there's just just pieces of fat in that liver. It's mediated by this alcohol, and it's reversible with cessation of alcohol. Now the next stage is called alcoholic hepatitis. So as you can tell from the name, there's inflammation and there's swelling of hepatocytes. There's neutrophil infiltration. That's due to damage causing inflammation, neutrophil infiltration. And you're going to see Mallory bodies. Mallory bodies are what we see here, and they contain basically just broken down keratin filaments, okay? Alcoholic hepatitis is also usually reversible. Finally, what's the last stage? Last stage is alcoholic cirrhosis. So that's what do we say cirrhosis was? It was that long-term chronic liver damage. Liver doesn't work very well because of this inflammation and fibrosis. So there's fibrous bands, there's regenerative nodules, and it's all in response to this chronic liver injury. So this is the last stage of alcoholic liver disease. We start with fatty infiltration, then we go to the inflammation and neutrophilic infiltration, and finally we get that fibrous bands, regenerative nodules, and cirrhosis. Now what will we see on labs? What was the labs that we talked about for liver damage? We talked about ALT, AST, and which one will be higher in alcoholic liver disease? Remember that AST is greater than ALT in alcoholic liver disease. This is very key here, okay? This tells you a lot. You see that? You know it's probably alcoholic liver disease. Okay, now we're going to skip all the way from hepatic toxicity to metabolic problems that can cause cirrhosis. So now we're going to look at non-alcoholic fatty liver disease. Remember we had alcoholic steatosis. Now we have non-alcoholic steatohepatitis, okay? Name tells you everything. It's fatty liver change, not due to alcohol. And the most common cause of this is from obesity and insulin resistance. Sometimes they call this metabolic syndrome. And what happens is this obesity and insulin resistance leads to fatty infiltration of the hepatocytes. You're going to get hepatocytes, they're going to get super fatty, they're going to balloon out, and if they balloon too much, they're going to get damaged. They're going to get degeneration and necrosis of your hepatocytes. And your chronic damage is what's going to lead to cirrhosis here in non-alcoholic fatty liver disease. Alright, next is hemochromatosis, another metabolic cause of cirrhosis. This is a disease with excess body iron. There's too much iron in the blood, and then this iron is going to get deposited in various tissues, causing organ damage, okay? And it results from an autosomal recessive defect in the HFE gene. What it's going to do with this problem in the HFE gene, you're going to get impaired ferroportin activity. Ferroportin normally takes iron in the blood and puts it into hepatocytes. That doesn't happen, so you have all this iron in your blood. Not good. Because ferroportin needs this HFE gene to be normal to work, okay? The other thing that you get falsely low iron sensing, okay? Your small intestine is going to think that your blood has very low iron because of this mutation. And what your enterocytes are going to do is going to increase uptake of iron from the small intestinal lumen, and then it's going to push that iron into the blood, and now you get iron overload. So you get iron overload both from small intestinal, falsely low iron sensing, and in the liver, impaired ferroportin activity. So clinical features, I told you, iron's going to get deposited in various tissues, specifically the skin, the liver. You're going to get it you can also get it in the heart and in the joints, okay? So you're going to get a classic triad here, or bronze diabetes. So it's cirrhosis, skin bronzing, and diabetes mellitus. The skin bronzing looks like that, okay? Trump doesn't have hemochromatosis, but that's what skin bronzing looks like. Hemochromatosis, bronze diabetes. Very classic triad. Okay, so memorize that, know it. Bronze diabetes is classic for hemochromatosis. So other things you can get, we talked about this in the cardiac lectures. but it can get deposited in the heart. It can either cause restriction so that the heart doesn't expand very well, or it can just cause dilated cardiomyopathy. And they get arthropathy which is joint pain. And in your labs, you're going to see increased ferritin and iron. Remember, ferritin is what carries the iron, so we have excess iron, so ferritin is increased. And the TIBC is decreased. TIBC stands for total iron binding capacity. And this measures how much iron transferrin, which is our iron transporter, transports iron on the blood, how much the transferrin can bind. And TIBC is decreased because most of your transferrin is already saturated. You have so much iron overload that there's not much more capacity for iron binding left, okay? The other thing to remember, you're going to see this in the heme lectures, but ferritin and TIBC go in opposite directions. When ferritin goes up, TIBC goes down. When ferritin goes down, TIBC goes up. Alright, so that's it. Treatment. How do we treat this? How do we treat this excess body iron in our blood and in our rest of our tissues? Number one, you do phlebotomy. That means you bleed the patient. You remove the patient's blood, and because the blood contains a lot of iron, you're removing iron. And so the patient's going to slowly replenish their blood stores, but the iron you have nicely removed. The other thing you can do is chelation, and the medication you use are the ones that start with DEF, DEF, iron chelators. So they bind to iron and help you excrete it. So deferoxamine, deferapone, deferoxyrox. If it starts with a DEF, it's probably an iron chelator. Next, Wilson disease. So hemochromatosis was a problem with iron. Wilson is a problem with copper. Again, autosomal recessive defect, this time in the ATP7B gene. What happens is you get decreased incorporation of copper into ceruloplasmin. Okay, ceruloplasmin is a protein that carries the copper. And then there's also decreased secretion of the ceruloplasmin into bile for excretion. So basically what's going to happen is copper is going to build up and it's going to deposit first in the liver, and then when it builds up too much, it's going to go to other organs, specifically the brain and the cornea. Okay, and it's going to cause problems based on all of these specific tissue depositions. So copper in the liver is going to cause liver disease. You're going to get hepatitis and cirrhosis. When it deposits in the brain, you can get neuropsychiatric disease. So very general stuff. One key one is Parkinson-like syndrome. So what was the symptoms of Parkinson syndrome? Do you remember that mnemonic? Remember this trap, okay? Remember, it's that pill rolling tremor. It's the rigidity, the slow akathisia, so very slow. And then the P is the postural instability. Okay, trap. And then you can have cognitive changes. You can have just decreased cognitive function, and then you can have the psychiatric stuff like behavioral changes like depression, irritability, and more. Just all you have to remember is neuropsychiatric disease and maybe just the Parkinson-like syndrome. Okay? Final thing you can see is deposition of copper in the cornea. It causes this Kaiser-Fleischer ring on the outside. The outer perimeter of the cornea, you get this golden brown copper deposition. Treatment here, similar to iron. Again, you have to chelate it. The way you chelate is with penicillamine. And alternative chelators include trientine or zinc salts. Okay. Again, Wilson disease, genetic defect leading to decreased incorporation of copper into ceruloplasmin and decreased excretion of ceruloplasmin into the bile. So actually, the other thing you're going to see is, anyways, that causes buildup of copper in your different tissues and then specific damage. Finally, alpha-1 antitrypsin deficiency. We've talked about this in the poem lectures already, but this is a gene mutation and leads to impaired secretion of antitrypsin. Antitrypsin's a protease inhibitor made in the hepatocytes. So proteases, what do? They break down protein. So this stops protein breakdown. So the problem is if you have impaired secretion of this antitrypsin in the hepatocytes, it's going to build up in the hepatocytes, and then that's going to be a problem. You're going to have too much antitrypsin in the hepatocytes. You're going to get hepatocyte destruction. You're going to have hepatitis, which is inflammation. And you're going to get cirrhosis. Okay? The other thing that's going to happen is you're going to get lung damage. Remember, what do we talk about this? We said that this inhibits proteases, but in the lung, if you're missing this, then the proteases are going to be too active, and you're going to get, especially the protease called elastase. It's going to break down the alveoli, and you're going to get pan-acinar emphysema, okay? Pan-acinar emphysema from alpha-1 antitrypsin deficiency. Remember that the centra acinar emphysema arises from what problem? From what behavior? It arises from smoking. Okay, so the clinical features of this is a patient with lung problems and liver problems. It's going to be a young patient with liver disease and shortness of breath because, first of all, they're young because it's congenital, so it's going to have earlier onset of all of these things. And then on histology, you're going to have PAS positive globules seen in the liver. Okay. The way I remember that is I remember alfalfa sprouts in your pasta, okay? Alfalfa sprouts in our pasta. Remember Whipple disease was also PSA positive. That's just staining. It's a type of stain. PAS staining. And Whipple disease had that foamy wet pasta, and this is the alfalfa pasta, okay? So that's alpha 1 antitrypsin deficiency. And that's it for all the other causes of cirrhosis. We covered the hepatotoxic causes. We covered all the metabolic causes. And then in previous lecture, we covered the viral hepatitis. And then we'll talk about the primary biliary cholangitis later. Okay, on to the next section.